Good afternoon, everyone, and thank you for allowing us the opportunity to be here. So today I'll be putting things into context, right? Somebody this morning said, our plenary speaker said, how do we put things into context? So I'm here to talk to you about vulnerable populations, why they're uniquely vulnerable, and use some examples from research studies that I've collaborated in or led. So when we're thinking about indoor environments, the main routes of exposure that we're usually worried about are inhalation, direct and, inhalation, dermal absorption, direct ingestion, right where we eat and drink. When we're talking about eating and drinking, we're also worried about infants because they are also eating and drinking, but from another source. Also indirect ingestion, as we've heard about, infants and toddlers tend to explore their environments by putting their hands in their mouth. Also, we're worried about transplacental transfer, right? Exposures to the pregnant mom can definitely affect the fetus. And also, we're concerned about, when we think about indoor exposures, we're thinking about what's in our air, what's in our dust. Those are primary pathways that we're usually concerned about. So ultimately, we're concerned about pretty much building occupants, right? But some of us are more uniquely vulnerable than others, and I wanted to talk about that today. Those include children, pregnant women and women of reproductive age, the elderly, as well as individuals with pre-existing conditions, low-income and underrepresented populations, and these are marginalized communities, communities of color, as well as workers. And we all know that some of these are not mutually exclusive, right? We can have low-income workers, we can have low-income minorities with pre-existing conditions such as asthma, for example. So why are children more vulnerable? Well, their body systems are still rapidly developing, right? For example, the respiratory system doesn't finish developing until early adolescence, so any exposures during critical windows of development could have potential long-lasting impacts. Their bodies are less able to detoxify and get rid of chemicals when they're exposed to them. Compared to adults, they eat, drink, and breathe more in proportion to their body size. Their breathing zone is also closer to the ground, and so that has implications for higher inhaled doses for select pollutants, particularly the ones that tend to be denser than air. Their behaviors can definitely expose them to more contaminants. We already talked about inadvertent ingestion and why dust can be an important source of exposure, but they also engage in risky behaviors, such as what we're hearing in the news a lot about is e-cigarettes, right? Because we think that they might be safer. And also, we've heard about this as well, the amount of time that they spent indoors, whether it's at the home, the workplace, which is actually schools for children, right? As well as childcare environments, right? We know that they may spend anywhere between 4 up to 12 hours each day for 5 days a week in these environments. Pregnant women and women of reproductive age, we know that the fetus is still developing, and exposures during different trimesters could have long-lasting impacts, and exposures during the preconception period could also affect fertility outcomes. Now, regarding low-income populations, they're usually living in substandard housing conditions, which are usually associated with poor building materials, as we have learned about from previous talks. Substandard housing conditions also sometimes imply pest infestations, which also then implies frequent pesticide use indoors. In fact, in a study that we conducted in California where we sampled both low-income urban and farm worker homes, we found that anywhere between 67 and 85% of households were reporting pesticide use in each location. In addition, proximity of the residents to polluting sources, that includes highways, that includes factories, that includes potentially pesticide-treated fields or pesticide-treated golf courses. Limited access to health information and healthcare, experiencing psychosocial stressors that can impact health. The lack of environmental health awareness. Housing options may be limited, and also they're disproportionately affected by hazardous workplace exposures, which we'll talk about in a little bit. So why are workers more vulnerable? They have more higher and continued exposures to chemicals. They also sometimes engage in strenuous and physically demanding activities, which could imply, for example, higher respiration rates and more inhaled doses. Take-home exposures pose a concern not only to continued exposures to the worker, but also other household members. And what I mean by take-home exposures is when workers, for example, who have been applying pesticides or been working with chemicals at the workplace, they go home, they wash their clothes with the rest of the families, or they go and hug a spouse or hug a child. That's another potential source of exposure to the household members. There's also personal behaviors like consumer product use that can add to the workplace exposure, which we'll learn about in a few slides. For example, the use of pesticides at home, the use of personal care products. Also, in worker population, safety training is not always provided or adequate, or even in the language necessary for your worker population. They have limited choices of where to work, and also limited control of the work environment. So now what I wanted to do is provide you some examples of what we've observed in these vulnerable and unique populations to kind of take the message home. So this is data from colleagues at Berkeley, where we were looking at levels of pesticides in the urine of pregnant women and children and compared them to those in the general US population using CDC national biomonitoring data. And regardless of whether pregnant women or farm worker children, what we're finding is that the blue bars here represent pregnant women living in a farm worker community, and the blue over here in these bars represent their children. And what we're seeing is that regardless of whether it's pregnant women or children, we're seeing much higher exposures in these populations. We also conducted, for example, an organic diet intervention study, and we know that diet is simply not enough to reduce your pesticide exposure levels, and that there's other drivers of exposure. The blue represents conventional diet phase, and green represents when our study participants were undergoing organic diet. And we're seeing that regardless of location, so these are farm worker children, these are urban children, these are all low income, by the way, and these are all the children together. And even though we're seeing a decrease in pesticide exposure as measured in the urine, we're still not seeing it go to non-detectable levels, right? It's still there. And this is after taking into account washout periods for, potential differences in metabolism. Some potential drivers for these exposures could be proximity of the residents to the fields, for example, for farm workers, households, substandard housing conditions, and high pesticide use, the time they're spending indoors, playing in or near treated fields. It is not uncommon for children who are waiting for their parents to be playing in the fields, and also take-home exposures. In this study, we found that among the farm worker households, 80% of them, for example, were wearing their clothing inside the home. And this is an example of occupational exposures in a particularly unique population. There is an estimated over 700,000 hairdressers in the US. And 95% of them are female, and mostly females of reproductive age. 13% of them are African American, and about 15% are Hispanic or Latina. And many of these are women who are working during the preconception period or even during pregnancy. In this study that I'm about to talk to you about briefly, we actually had 2 pregnant women participating. One of them was due like any minute, any day when we recruited her. And so this is a population that is very unique. They're being exposed to multiple chemicals on a continual basis. As you see here, these, for examples, are different VOCs and different products that could be either present, emitted, or formed in a lot of these products. And they're also exposed to other chemicals, including phthalates. And so we sought to sort of, there's also, emerging concerns that select products or services could expose hairdressers to harmful chemicals. And in particular, our concern was, there's recent research showing that products that are marketed for use in ethnic minorities, including African Americans, contain a lot of endocrine disrupting compounds, lye, toxic solvents, and adhesives, but we don't have a lot of data on exposure and health impacts, in particular to salon workers who are serving these populations and who they themselves may be using these products for personal use. And so this pilot study sought to answer some of these questions in terms of what does exposure look like in this population? And what we're finding is that, for example, with regards to biomarker concentrations for phthalates, we're finding that some of the products and services provided are driving, or are associated, I should say, with some of the services being provided. So for example, Brazilian blowout, those who were reporting this, providing the service had 2 times as much meat concentrations in their urine. Those who responded to providing locks, which is a natural hairstyle, we found that they had much lower concentrations than those who did not provide the service. And we think that this may have to do with the fact that this is what we call a natural hairstyle. And so maybe if you are not providing the service, you're more engaged in using more heavier chemical products and services. We're also seeing that MEP concentrations, which is a metabolite for diethyl phthalate, present in a lot of cosmetics, fragrances, and hair products. Median concentrations are statistically significantly higher in this hairdresser population compared to women of the same age range in the general US population. Again, this is using the box plot in red is women from the general US population using CDC biomonitoring data, and the one on the left is for the hairdressers in our study. We also took some air samples, and we found that median 8-hour time-weighted average benzene concentrations in air exceeded occupational guidelines and limits. Each of these box plots represents measures taken in each of these salons. And again, these are salons that are focusing where the clientele is mostly minority populations, African American, Latina. And just as we know that benzene is carcinogenic, it can impact menstrual cycle and sperm count, motility, and concentration, and it can definitely affect the immune system. And just as a reference here, we can see that the median concentrations have definitely exceeded the occupational limits and guidelines, and ambient outdoor benzene concentrations tend to be much lower. It's the orange bar that you see here as a point of, so you can see as a point of reference. Similar findings were also found for other chemicals in these hair salons, including here, for example, we also looked at 8-hour time-weighted hours concentrations for isopropyl alcohol in salon as well as in office settings, and we're seeing here that they're drastically much higher than those observed in office settings. And also, again, median concentrations are exceeding occupational health limits. And right now in our field, and as we've heard from all these talks, we know that we face a lot of challenges when assessing both indoor and outdoor exposures, right, and the health risks. There's what we know and there's what we don't know. There's a lot that we don't know, and that's why we're here, right, to talk to each other and to initiate collaborations and keep that ongoing. For example, safety of replacements is usually not known, right? We're quick to replace something because we need to phase it out and we're finding some things that are wrong with it, but there may not be enough research on the replacements that we're using. We don't know how different chemicals are going to affect us by sex, by race or ethnicity, by other sociodemographic factors. We need to take into consideration effective science communication in order to translate our science, because eventually, why are we doing this? Because we care and we want to mitigate exposures, right? So we need to also do a better job of translating the information that we're getting from our studies to the populations that are being affected by this. So in terms of research directions and need, we really need to ensure that we're including these underrepresented and understudied populations because they are experiencing a lot of high exposures. We also need to be cognizant that we need to build community partnerships and gain their trust, as well as engage stakeholders. We also need to consider our environment broadly, for example, considering mixtures, considering the fact that when we're talking about environment, we're talking about not only chemical exposures, but where this person lives and other factors that can affect and impact their health, such as psychosocial stressors and cultural factors that could definitely hinder exposure mitigation efforts. Also, we need research on tools to avoid new hazards of regrettable substitutions, and there's a need for expecting and solid exposure science research and multidisciplinary collaborations, right? It's not enough to know that X causes a disease. We need to know how to properly measure the different chemicals that we're exposed to. And I'd like to end with this, which is science translation is key in order to inform and develop practices to protect public health. We need to develop interventions that are sustainable, that are feasible, and they're accessible to the target populations, especially when we're talking about these vulnerable populations that are low income and marginalized, and they also need to be culturally appropriate. We can't assume that one intervention is going to work in different populations. As we saw here, here is a population that is using a specific products that are marketed to them. Not everybody's going to be using the same thing. And we also need to empower these vulnerable populations by knowledge, by giving them access to how to improve their environments. It's not enough to tell somebody you need to move. It's not enough to tell them, hey, buy a new couch, because that may not be feasible. And I'm out of time, so I'd like to acknowledge all of the funders, all of my collaborators, amazing students, and AAAS and the Alfred Sloan Foundation for having us here today.